Right, thanks so much, Vicky and JC, and Christine and I would like to thank Macmillan Cancer Support for asking us to do the presentation. We're going to share the presentation today on why people get PSA tests, prostate cancer, some of the investigations that patients may go through, and then treatments. And as Vicky said, please do put questions in the chat box. I've got it open. And we'll try and answer them as we go, or we can do some more at the end. So if we could move on to the next slide, please. As I'm sure all of you are aware, prostate cancer is a very common cancer. Unfortunately, it's the commonest male cancer, barring some skin cancers. So its frequency is very high. It probably accounts for about 25% of new male cancers, and about 45 to 50,000 men a year are diagnosed with it. Unfortunately, not everyone survives treatment, and so there is a significant mortality from prostate cancer, but many men have successful treatment, and so we're going to discuss today how that might be managed. If you look hard enough, probably most men would have some early prostate cancer, but actually 1 in 8 over their lifetime will be diagnosed with prostate cancer. So that means a lot of men are living with or after treatment for prostate cancer. So there's a significant health burden, but a significant number of men live quite happily with it. We could have the next slide, please. In terms of the age, clearly it's a disease of slightly older men, but if you look hard enough, you do find it in younger men, and there were some post-mortem studies of men in their 30s and 40s who died of other causes some years ago, finding disease in men in their late 30s to 40s. However, because of how people present and how it's picked up, it tends to be men in their 50s, 60s, 70s and beyond, with the incidence as per the graph below. But there are various factors that may mean that younger men should potentially be screened, which is on the next slide, if we can look at that. So what are the risk factors? Everyone's very interested in how you might be able to identify disease early, as that potentially might bring easier or better cure rate. And is there anything you can do in your lifestyle to change it? So there's a few things you clearly can't change with prostate cancer. You can't change your age, you can't change your relatives, and you can't change your ethnicity. And there is certainly a significant instance of familial prostate cancer in first-degree relatives, and this increases your risk. So father, brothers, uncles with prostate cancer, potentially, depending on their age at diagnosis, will increase the risk. This is related to various genes. One of them is called BRCA2, which initially was identified with breast cancer, but appears to have a link with prostate cancer. So overall, we believe about 5 to 10% is what is termed genetic. Clearly, it's all gene related, but about 5 to 10% are probably genetic. The rest are termed sporadic, which is getting prostate cancer without a strong family history. Ethnicity is very important risk factor for prostate cancer. It is higher in Afro-Caribbean and Black population, significantly higher in some Caucasians sort of in the middle, and then some other ethnicities would have a lower risk. What also seems to be an issue is obesity, which clearly is an important and increasing health problem in our society. It is possibly related to how some testosterone is managed in the fat cells. It's a little bit unclear, but clearly also surgery in men who are significantly overweight is harder, and outcomes may not be quite so good. So not only may you have an increased risk, but they may also mean that treatment is harder to achieve. There are a couple of other factors as to where the obesity is that have been looked at, and it goes with hypertension, and central obesity seems to increase the risk slightly. We could have the next slide, please. Then. So the Movember Foundation, which you may have heard of, they very supportive of men's health, particularly testis and prostate cancer. And they suggested at 50, it might be worth going and having a conversation with your doctor about PSA testing. As I said, if you're in one of the groups particularly at risk, it's probably worth doing that a little bit earlier, probably 5 years or so earlier. But there's no criteria for that. But it's worth having a conversation if you wish. Thank you. Next slide. So apart from what associated with your ethnicity and age and family history, is there anything you can do to lower the prostate cancer risk? Well, keeping a sensible weight and exercise probably is the most important. There have been various studies. The SELECT trial, which was published some years ago, looked at vitamin E and selenium. And people think that taking vitamin E and selenium might have helped, but in fact, it didn't show lower the risk at all. And potentially, I think in one of the arms of the study, increased the risk of type 2 diabetes. So that doesn't seem to help. There have been numerous studies, not always particularly well controlled, between placebo and treatment arms, looking at vitamins and supplements. Unfortunately, none of them have really shown any reduction, but clearly people like to take things that they think may benefit their health. And because we don't clearly know the cause, we find it difficult to say what might prevent prostate cancer. Testosterone is very important in the development of it, but reducing testosterone prior to diagnosis actually slightly increases your risk, slightly perversely. So although we, and Christine will talk about this later, although we do use reduction in testosterone as a treatment, you actually need a normal testosterone in early adult life. Otherwise, your risk can increase slightly. So we don't really have much in the way of preventative treatments. Thank you. Next slide. So these are some of the studies that have been published. As I said, not all of them great studies. Some of them a little bit small numbers and a mixed group. Some people like to reduce their red meat or dairy. There really isn't that we can find any particularly good evidence for that. It is one of the cancers that smoking and alcohol seems to have no effect on. People have reduced and increased calcium without benefit. Cholesterol, difficult. Statins, which a large proportion of the population on was a potential exciting drug that might have reduced risk a few years ago. Then there were studies suggesting it didn't make any difference. I don't think you can take it to reduce your risk of prostate cancer. There's certainly no strong evidence for that, but it doesn't seem to have a detrimental effect. Various studies shown potentially green tea and some of the contents of green tea might do. Coffee showed an increase, a decrease, and no effect. So I think we can say probably you can still have your coffee. Physical activity, probably related to obesity, generally probably a good effect overall. Again, aspirin keeps coming up with colorectal cancers and potentially with prostate, maybe a mild reduction. There was a study many years ago looking at the effect of vasectomy. It wasn't well run, and there was the initial report suggested that vasectomy might increase your risk. The next study showed no effect, and I think on balance we feel this has no effect. And baldness maybe, I think it has clearly no effect. But again, studies have been looking at that. Thank you. So if we look at screening, and I'll briefly discuss about why we don't have a national screening program for prostate cancer, but about 50% of men in their 50s, if you look hard enough, as I said earlier, will find prostate cancer. So it's about the same as your age in decade, 80% of 80-year-olds, but a significantly smaller proportion of men will actually be diagnosed. An even smaller proportion will suffer from prostate cancer, and then about 3 to 4% of men might die from prostate cancer. So the old adage that people live with their prostate cancer remains largely true for the majority, but unfortunately not for all. And we see men presenting with advanced disease, which will significantly shorten their life, despite having had PSA testing around for at least 30 years or so. Next slide, please. So I'll just mention the screening a little bit more. So some countries have sort of pseudo screening programs without testing everyone. PSA is the marker that's used in most screening, or in all screening programs, and it has its faults. So it will pick up some prostate cancers, but your PSA, the blood test, may be raised without prostate cancer, and it may be normal with prostate cancer, and you may have prostate cancer and have a normal PSA. And therefore, it is not a particularly good test for population screening. And you need to screen 1,700 men to sort of find one prostate cancer. There's a big discrepancy between picking up. So what we tend to find is case finding, men presenting to their GP with symptoms, and we'll talk about that a bit more. So if we move on to how it might be diagnosed, why do men go to their GP, or how do they get a PSA test? So men may go with what is termed lower urinary tract symptoms. So this is waterwork troubles, and they may present with a slow flow, getting up at night, urgency, frequency. Now, most of these symptoms, it's important to realize, are related to normal bladder aging, perhaps increased size of the prostate, and are not prostate cancer specific. So many men clearly get very anxious about these symptoms and thinking they've got prostate cancer. Indeed, they may, but it may just be running alongside low urinary tract symptoms related to slightly enlarged prostate, or some form of problem with the bladder not functioning properly. They may have a friend or family member who's recently been diagnosed with prostate cancer. This is common at the golf clubs and other things. There's whole force going around of men who've all been through our service with prostate cancer. Some men may present with erectile dysfunction. Problems with erections is very common in men, and it is rarely caused by prostate cancer, but clearly can be. A lot of men are prompted by their wives or partners to go and get a PSA test, and then do that. There are some excellent charities who organise community blood tests, Rotary clubs, etc. Lions. The little picture on the side was PSA teas, coffees and cakes. So that often happens. There is a finger prick PSA blood test that's done in some places, not brilliantly accurate, I think, but some charities, Picasso and colleagues have done PSA blood tests at football matches and things, and this can be helpful. So can generate referrals. And then very often completely unrelated symptoms, and someone, a GP or practice nurse, just adds a blood test along the way just to see what it is. So that can happen. And so many men have no symptoms at all and have a blood test with a PSA that's elevated. Thank you. Next slide, please. So PSA stands for prostate-specific antigen. It's an enzyme, so it's a chemical in the blood test, originally identified as the chemical that liquefies semen after ejaculation. So it's normally present at very high levels in semen, and a certain amount of it leaks into the bloodstream quite normally. And it is thought probably that some of the prostate cancer cells are a little leaky and leak more blood test, more PSA. And this blood test PSA may well indicate prostate cancer, but it will go up with straightforward cystitis, urinary tract infections, or prostatitis, which is either a chemical or a bacterial infection of the prostate gland, which may or may not cause symptoms. So many men will not know they have prostatitis. Doesn't need treating in that case, but it may put your PSA up. And as the prostate gets larger as you get older, prostate's bigger, it makes more PSA. Therefore, we have not only age-related PSA ranges, so as your ages go up in decades, we increase what is termed the normal. But if you have some imaging of your prostate, such as an ultrasound or an MRI, we can then compare the PSA with the size of your prostate and then say whether you have a normal PSA or not. Thank you. Next slide. So there are age-related ranges. When PSA was originally available, the sort of 4 nanograms per mil was viewed as the normal. This has come down to 2 or 2.5, depending upon your reason, in men in their 40s and 50s, and creeps up over the decades to a PSA of 10 for men in their 80s. If your PSA is higher than the so-called normal ranges, then your GP may refer you on a 2-week wait, strict fast-track referral, or they may have a discussion and say, let's repeat it. If it's marginally elevated, let's repeat it in 6 to 8 weeks, maybe up to 3 months, and see if it remains elevated. It is very unlikely that anyone's going to come to any harm with a borderline elevated PSA if referral is deferred. And if the PSA then comes down to normal, then you could perhaps avoid the referral. So what happens to us? All these referrals come in to our fast track team, and our consultant of the week screens them all, and we'll often try and arrange a second PSA if it's just mildly elevated. We generally try and at least get a urine dipstick or a midstream urine to make sure that the patient doesn't have urinary tract infection, because we're about to start them on a pathway with some fairly potentially invasive tests, and we need to make sure they haven't got a straightforward cystitis. A lot of men go what is termed straight to test. So prior to seeing us in clinic, they will have an MRI scan arranged. This is called a multiparametric MRI, and this may or may not have, well, a true multiparametric normally has contrast injection and then various sequences through the prostate to try and identify whether there might be tumor there. It will not tell you whether you have prostate cancer on its own. You need to have the PSA, you need to have a rectal examination, and normally a biopsy to prove that, but it will give you a very strong indication as to whether a biopsy is needed and whether prostate cancer might be present. The initial screening MRI scan may take about 15 minutes, so patients are in and out very quickly for the initial MRI scan. Sometimes we need to bring them back for a second scan. We may also arrange a flow test where they wee into a small funnel and a machine measures the flow. This is important as some of the treatments require a good flow, such as brachytherapy, which we'll talk about a bit later. And whilst they're there, the patient, or the man, will have his bladder scanned with an external ultrasound just to look at the amount of urine left behind. So those are the initial tests that may well happen before they see a clinician or a clinical nurse specialist in the clinic. And therefore, it's really important that at least the urine test, and what we don't have there, they also need a creatinine to measure their kidney function, because if you're going to have an injection of contrast at the MRI, we need to know what their kidney function is like. So all of this needs to be done before a fast track referral is arranged. Thank you. Next slide. So where is the prostate? I'm sure you're all aware if you're helping patients through decision making, but it's situated low in the pelvis, fairly inaccessible. It sits a bit like a donut around the urethra, around the water pipe, below the bladder, and its role in life is to produce seminal fluid. So most of the fluid that's ejaculated comes from the prostate gland and some little glands behind it called the seminal vesicles. Only a tiny amount comes from the testis. About 1% of ejaculatory fluid comes from the testicle. It is situated just in front of the rectum, which means that examination of the prostate, at least one side of it, is in fact fairly easy, and the rectal examination is performed routinely in clinic and may also have been done by the GP. Thank you. Next slide. So the prostate is not one straightforward organ. It is made up of various bits, a bit like those dolls that all fit together. There are various sections to the prostate, and some of them cause more problems with prostate cancer, and some of them form more problems with benign prostatic hyperplasia, so normal enlargement of the prostate, which may then cause more problems with waterworks. So the upper slide shows the transition zone, the upper image, and this wraps around the urethra, and this is the bit that normally causes benign enlargement of the prostate. There's then a little bit called the central zone, and then the bit around the outside is obviously called the peripheral zone, and that's the bit mainly that you can feel when we do a rectal examination, and that is where most, but certainly not all, prostate cancers were formed. When I was training prior to MRIs being frequently, well, they weren't done at all for prostate cancer. The only bit you could biopsy was the peripheral zone. So we really thought that most prostate cancer occurred there because that's all that was accessible. Now we appreciate, with the advent of everyone having an MRI scan, that prostate cancers around the front of the prostate do occur in the transition zone and in the central zone, and another little bit called the anterior fibromuscular stroma, but it is less common than in the peripheral zone. Thank you. Next slide. So patients who've had their MRI scan, we do then need to still examine the prostate. It is very important. We will pick up things that the MRI doesn't pick up. So although patients say, well, I've had a scan, I don't need an examination, we do say it's really important to examine the prostate, and that's still done. And we would encourage primary care GP to do that as well, because, as I said, not all prostate cancer will produce PSA, in which case the only way to pick it up and make a referral is if they examine the prostate. Thank you. Next slide. So why do we do it? Well, we do get some idea of the size of the prostate, although once the patient has had an ultrasound or an MRI, that's better. If the prostate is very tender, there's a condition, as I mentioned earlier, called prostatitis, and this will put your PSA up, and it may mean that we hold off a biopsy. And prostatitis looks almost identical to prostate cancer on an MRI in many cases. So if the prostate's tender, it's important to know that. We feel for nodules. We still like to try and stage the prostate cancer in this way, and staging means how much or how advanced the prostate cancer is. And when you, as a urologist, do hundreds and hundreds of rectal examinations, actually you get reasonably good at staging it. And putting that in with the MRI can be very useful in then guiding the patient. As I said, not all prostate cancers produce PSA, and most men with prostate cancer, certainly early prostate cancer, don't have any symptoms at all, and therefore it's part of the diagnostic process. Thank you. Next slide. So prior to seeing it in clinic, virtually everyone will have an MRI prostate, or we see them if we're not too sure whether they need it and then get one. It can identify areas to target, and the little image over there shows a gentleman's prostate with a fairly reasonably advanced prostate cancer. You can see the hip joints on either side, the two circular areas. The black area behind is the rectum, and the sort of smudgy grey area in the front is the prostate. And you can see the zones very clearly on an MRI prostate, and also potentially identify areas to biopsy, so we don't just do random biopsies. It will show us whether the disease is spread just outside. It will show us areas in the bone locally and lymph nodes where prostate cancers often spread to first. Some of the newer pacemakers and defibrillators are MRI compatible, but the MRI doesn't use ionizing radiation like an X-ray or CT. It uses a huge magnet. And so it's very important, if patients have a pacemaker or defibrillator, that they know whether it's MRI compatible or not. It's a disaster if people go in without the right sort of defibrillator. So they may not be able to have an MRI, in which case we have to rely on CT scans. Thanks. Next slide. So the Fast Track Clinic is run pretty much every day. We all see Fast Track patients. We'll take a history, family history, we will examine them, and do a rectal examination. Assuming they might have had their MRI first, we often show them the images, discuss their PSA, and then proceed on to further tests. Interesting study, probably 2-3 years ago, demonstrated that about 20% of men, if they have a normal rectal examination, normal PSA, and an MRI, about 20% can now avoid a biopsy. So our number of biopsies have fortunately reduced slightly, because clearly it's an uncomfortable and invasive test, and we'd like to reduce it down if possible. Thank you. Next slide. So the men who come through, this might be a sort of model of the pathway that they might go through. This was published by NHS England, implementing a timed prostate cancer pathway, I think 2019. So you've got day 0, fast track, visiting a GP, then hopefully having a check to exclude a urinary tract infection. We will receive the fast track referral. As I said, we probably will arrange an MRI beforehand. We'll see them in clinic, discuss the need and the role for a biopsy. They will then have the biopsy done. We then wait for the pathology. If it's clear, we may write to them or ring them and say, you don't need anything further doing, or we're going to follow you up. And if it comes back, unfortunately, showing prostate cancer, they will be discussed at the multidisciplinary team meetings. The MDT will communicate that to the patient and then discuss treatment options with them. Next slide, please. So still probably the commonest biopsy route in the UK, although very much being phased out over the next year or two, is a transrectal biopsy. The prostate, as indicated earlier, is very easily accessible via the rectum, and traditionally it's gone from 4 to 6 to 8 to 10 to 12 biopsies, and the biopsies, the prostate is anesthetized with some local anesthetic and biopsies taken. The men are given antibiotics beforehand. The risks are some blood in the urine, blood in the semen, and blood in the stool. Most of this is actually reasonably mild and settles. The reason we're phasing this out is the risk of infection, and one of the antibiotics we use, ciprofloxacin, has been widely used around the world to treat all sorts of things, and resistance has become increasingly common. So infection risk has increased to the point where it's now becoming a significant problem. So this biopsy, type of biopsy, is being phased out. It also is very difficult to sample anything but the back of the prostate. The risk of retention with this is in fact quite low, but it's a local anesthetic procedure taking 15 minutes or so. Next slide, please. So 10-15 years ago, the prostate template biopsy or transperineal biopsy gained popularity, and we now perform a huge number of these, as does every centre. Some of these are performed under general anaesthetic, and the needle goes through the skin behind the scrotum, through the perineum. It has a very low infection risk because the skin can be cleaned. And we're now moving away from, we're going to start, as many centres are doing this, under local anaesthetic, so-called precision point, or the various ways of doing the biopsy. But this will become the standard, and under local anaesthetic, it will become the norm for biopsies. It has a very low infection risk, slightly higher perhaps risk of retention, and because of some bruising around the prostate, which is perhaps a little more common if you take a lot of biopsies, some men notice some temporary problems with erections, but it does seem to settle. It is possible to target much more accurately areas in the prostate that have been seen on the MRI that's of concern. And although initially a lot of biopsies were taken, we now we target lesions much better than just taking random biopsies. Next slide, please. So if diagnosed, and if your PSA is over 20, a proportion of men will go on to have a bone scan. Prostate cancer is one of the very common cancers spreading to the bone. And this slide here shows a gentleman with metastatic disease. The dark black areas in the ribs and pelvis and spine show metastatic disease. So we use that for staging if they've had an MRI scan beforehand. Next slide, please. So one of the things the biopsy tells us is the type of prostate cancer. So we have the staging from our examination and the MRI, and then we have the type of prostate cancer from the biopsy. Many years ago, an American pathologist called Donald Gleason described this staging system. It is slightly confusing in that originally they described 1 to 5, and then the two commonest areas. So you get 2 scores out of 5, making a score out of 10. Over the years, 1, 2s, and 3s have all been lumped together. So if you like, the slowest growing or the best prostate cancer is a Gleason 3+3, and then you get 3+4, 4+3, 4+4 making 8, 4+5, or 5+5. And we've now simplified that to call it grade group. So grade group 1 to 5 down the left-hand side. So grade group 1 disease is essentially almost a normal prostate cell, but showing some early cancerous changes. And grade group 5 is an aggressive, rapidly growing tumor. Next slide, please. In terms of staging, this is done by rectal examination and MRI, bone scan, and this slide just outlines the various stages. We use what's called the TNM staging, tumor node metastasis. So patients will have a T stage, an N meaning have they got lymph nodes, and M meaning metastases, have they got metastatic disease. So everyone will have this. Patients will hopefully have this explained by us and Christine and her colleagues when we diagnose them. Next slide, please. So at this point, I'll hand over to Christine, who's going to talk to us about the treatment.
Thank you, Andrew. So now we know how prostate cancer is diagnosed, we're going to look at the treatments that are available for treating both localized and locally advanced prostate cancer. So we're really looking at stages 2 and 3 here. Next slide, please. So how do we guide men? There's going to be a cohort of men with T2 disease, so that's organ-confined prostate cancer, that are suitable for all of the treatment options. And there are 4 main treatment options for these people. Either active surveillance, surgery, radiotherapy, or brachytherapy. And we're going to go through each of those in turn. Next slide, please. So patients will often come to clinic with preconceived ideas that are actually often wrong. Chaps will come in saying that they think that surgery is best because cutting it out is going to be the best way of curing the cancer. But that's not actually the case, because each of the active treatment options for prostate cancer are equivalent in their cancer cure rates. It's the side effects of these treatments that are very different, and so we have to spend time unpicking their preconceived ideas, telling them about the treatment options in detail, and then helping them to come to a decision. Next slide. So as a cancer nurse specialist team, we are available to see all patients who have been diagnosed with prostate cancer. We go through their treatment options, we provide them with the information, we give them a lot of written information, and then we give them our telephone number so that if they've got further questions, they can ring us to clarify points that they didn't understand. Or if they didn't bring their partner along, they can arrange to come back and see us in clinic and go through it all again with the partner available. And then they'll ring us with their treatment decision, and we will then put them onto the right pathway. Next slide. So there's 3 main aims when looking at treatments for prostate cancer. Obviously, a cancer cure is ideal, and then we need to aim to preserve continence and preserve sexual function as best we can. But unfortunately, all treatments for prostate cancer do have an impact on sexual function, and we'll cover that as we go along. Next slide. So starting with active surveillance is suitable for patients who have a low volume of prostate cancer in grade groups 1 and 2. So that's the Gleason 6 and the Gleason 7, but the low end of Gleason 7. These guys, we know that prostate cancer grows quite slowly over many years, and so we can safely watch their cancers. And we'll talk about how we do that. So the next slide, please. So basically, we monitor their PSA at regular intervals with the aim of detecting any disease progression before symptoms develop. If we've got any concerns at all at the start of active surveillance that we may not have captured the true stage of their disease, if they've had a trust biopsy but their PSA is higher than we were expecting or something like that, then we'd offer them an early template biopsy to get a better picture of the prostate. But if that still shows low volume, low grade disease, then active surveillance is an option for them. And the big advantage of active surveillance is that actually, if they're not being treated, they're not getting side effects. So that's great, because some of the side effects of the treatments can be life-changing. But unfortunately, it's quite difficult for some men, knowing that they've got cancer that we're not actually treating. And some men, even though active surveillance is the recommendation, really can't cope with that psychologically, and so do choose to have a treatment rather than no treatment at that point. They're few and far between, but it does happen. Next slide. So I'll hand back to Andrew to discuss the surgery.
Thanks, Christine. Surgery everywhere in the UK is performed robotically. I'm not aware any men really now having normally for open or normal keyhole surgery. So 8 years ago, we were lucky enough to get our Da Vinci robot. So this is essentially a surgical assistant. It's not a true robot in that it doesn't do anything independently. And the surgeon sits in a console and controls the instruments with hands and feet. We have normally a surgical first assistant who's either an experienced theatre nurse or ODP at the side of the patient to help with the operation, put clips on and things, and then obviously also scrub nurse and the rest of the theatre team. Surgery means, so RAP means robotically assisted radical prostatectomy. And this is for men who have organ confined disease, so disease confined to the prostate, so their MRI scan shows nothing significantly outside the prostate. If they've had a bone scan, that has to be clear. We can treat stages T1, T2 and early T3 with this if it's an extensive T3 disease, which means it's outside into the fat around the prostate. They're almost certainly better treated with radiotherapy, but clearly there are exceptions. So it means completely removing the prostate and joining everything back up together again. And over time, so when we did this operation open, men were in hospital 3 to 4 days. When we did it with normal keyhole surgery, it was 2 days. And now the majority of men stay 1 night in hospital. They will have a catheter for generally 1 week, sometimes a little bit longer, and we'll show them how to manage that. The patients, when they go home, sometimes feel a bit puffy around the eyes because they are in, unlike this picture here, they are in a steep head down position so that we can access the pelvis. They have 6 little incisions or cuts in the tummy, and the prostate comes out via a slightly bigger incision above the belly button, which is where the camera goes in originally. So the camera goes in above the belly button, and then there's 3 other robotic instruments and 2 other ports or tubes going in for our assistant to put clips in, use a sucker, etc. The view in theatres is on a 2D monitor, so a normal high definition screen, but for the surgeon, the head in the console gives us a 3D view, which is amazing. It's a twin tip camera on the end of the scope, so we get a 3D view. And the other advantage is that the instruments give you your hands back inside, essentially. So normal keyhole instruments, laparoscopic instruments, are straight, and all you can do is work with a straight instrument. This has a complete flexing arm on the end. It's actually more flexible than our wrist, so you can do 1 more turn than your wrist can. It is an amazing piece of equipment. It's expensive, but it is the standard now for surgery in the UK, and has reduced blood loss, overnight stay. I think continence is better, and hopefully trying to do nerve sparing or preserve the nerves to the penis, which are under 1 millimeter in size, and they're just stuck, unfortunately, on the side of the prostate. It is better for that. Next slide, please. So what are the side effects of surgery? Well, in men, normally the prostate has some muscle called smooth muscle in it, which is non-voluntary muscle. It's muscle we can't voluntarily contract, and that, for men, normally sitting or standing, keeps you dry. There is then voluntary muscle, which is pelvic floor muscle, which the muscle, voluntary muscles, use your hands, any normal muscle, and if you're sitting on the bus, sitting in the cinema, desperate not to pass urine and squeezing, that's the pelvic floor muscles. So the smooth muscle keeps you dry normally, but that is certainly disrupted and largely removed because a significant proportion of it is in the prostate. And therefore, one of the understandable and one of the risks of surgery is urinary incontinence. Most of the studies show that at a year, about 5% or 1 in 20 men will need more than one small pad a day to keep them dry. So when the catheter comes out at a week to 10 days, some are dry immediately, but unfortunately, not everyone is. And over the coming weeks and months, they need to do their pelvic floor exercises. And they do generally get a lot better, but it can be a bit of a testing time and a bit disheartening for some men at that stage. So I always warn them that it can be bad, but a few months down the line, it normally improves. The other aspect, as Christine mentioned, is problems with erections, and the nerves are tiny. They are not like the nerves to the legs, which look like pieces of electrical cable, which sit on the side of the pelvis, and we see one of them when we're doing this operation. The nerves to the penis are under 1 millimeter, and they're in a bit called the neurovascular bundle, nerves and vessels, which sit together on the side of the prostate, and we can try and pick those away, but it is difficult. And therefore, as Christine said, men do unfortunately suffer problems with erections. It is also true that in this age group, erections may already be a little bit tricky, and tell people they've got prostate cancer, tell them there may be a problem afterwards, and then do an operation. And unfortunately, erections can be difficult. So we treat everyone who would like to try and preserve their erections afterwards, if they've had any form of nerve sparing, with sildenafil, which is another name for Viagra, or tadalafil, Cialis. When we did the operation open, the ability to get a join was harder, so a little bit of urine irritated the join there, and a narrowing between bladder and urethra was probably about 1 in 10 men. It's now well under 1%. So bladder neck stenosis is rare. As we said, continence, erections, and cancer cure are the 3 main aims. So the pathologist looks at the prostate to see whether the prostate cancer has reached the edge of the prostate. Hopefully it won't have done, and we will check their PSA at 6 weeks. Clearly, removing the prostate not only affects on erections, but means that although the sensation of orgasm remains, no fluid is ejaculated, and therefore infertility ensues. So clearly appropriate for some men to bank sperm preoperatively if they are hoping for further children. Rectal injury, the rectum is about 2 millimeters from the prostate, and it's extremely rare, but is a significant complication if there's a bowel injury, and the patient may require a temporary stoma to deal with the bowel contents. Saying that, the majority of men go home the next morning and hopefully are fine and recover very quickly from this procedure compared to open surgery. Next slide, please. Christine, back to you.
So an alternative to surgery then is external beam radiotherapy. So whereas the surgery takes place in Bournemouth Hospital, radiotherapy is over at Poole. It's carried out on a Monday to Friday basis, and it takes 4 weeks to give a full dose to the prostate. So that's 20 visits in total. So some men use this as a reason not to go for radiotherapy because they find getting to the hospital every single day for 4 weeks is too much, especially if they live a long distance from the hospital. But there are ways around that, and there are certainly volunteer drivers and things like that. So if patients are struggling to get to the hospital, then we can arrange hospital transport if they need it. So radiotherapy, obviously the patient lies down on the couch. Now, prior to starting radiotherapy, they have a planning scan, which is a CT scan. That maps the prostate, and they work out, how to shape the beam to the shape of the prostate. And at that appointment, they get 2 tiny little tattoo marks put onto their abdomen. so that each and every time they arrive at the department, they're lined up using infrared beams that come across the room in the same position, so that the dosing is as accurate as it can be. So whilst they're lying down, as you can see from the diagram there, the bladder is directly above the prostate, and as we've seen, the rectum is right behind. And so as the beam is penetrating into the prostate, it is going to hit bladder and bowel as well. And so that's why we get side effects from radiotherapy, because of the positioning of everything. Next slide, please. So short-term side effects of radiotherapy, bladder irritability is a big thing. So a radiation cystitis. So the radiotherapy irritates the lining of the bladder and the water pipe, causes patients to have urgency, often at night as well, frequency, certainly needing to empty the bladder quite quickly. And then a burning feeling sometimes when they're passing water. So just like a bacterial cystitis, it stings and burns when you try to pass water. This is a radiation cystitis. So antibiotics don't help because it's not a bacterial situation. So it's sort of put up with it, unfortunately. Occasionally men can go into retention, so they need to have a catheter popped in during radiotherapy. But if we've noticed that they've got a bit of obstruction prior to radiotherapy, then we can sometimes do a small operation to core out the central part of the prostate before they start treatment, to give them the best possible chance of not going into retention. So that'd be a channel TURP that we would arrange before radiotherapy started. And then the radiation can also cause a little bit of bleeding, and they may get some blood in the urine as well throughout treatment. Next slide. So bladder and then bowel issues, so a radiation proctitis. And this comes with a whole host of sort of scenarios. So they might start to pass a lot more wind than usual, and that can sometimes be a bit wet, unfortunately. They might get very loose or watery bowel movements, a bit like diarrhea. And they may need to empty the bowel a lot more often than they would normally, and perhaps have to rush to the toilet. Mucus is also a bit of an issue during radiotherapy. So the bowel starts to overproduce mucus. There's a sort of a protective mechanism, really, but that then translates to the patient passing the mucus and then having to obviously wipe a lot more, and it's got a bit of a strange smell to it. They may get feel like they need to open their bowels all of the time, but they obviously don't need to. So a feeling of fullness, sometimes a bit of pain, and then bleeding can be quite common from the back passage during radiotherapy. So we always say to the patients that it's very normal if you bleed during your treatment, but if you were to bleed, say, 2 years later, that's not normal, and you really must get that checked out. We try and make sure that they're aware of that. It's very rare for them to get any actual incontinence from the back passage. It does happen very, very occasionally, but it's incredibly rare. Next slide. And then during treatment, obviously, the body is absorbing all of the high energy X-rays that the radiation is providing, and so it does tire them out. They get very tired and fatigued during treatment. They can end up with some problems with ejaculation, assuming they can get an erection, because the prostate produces the fluid, and obviously the radiation affects that. And they can get some sore skin, so it's a bit like a sunburn reaction, and the pubic hair can also fall out, but that should grow back in time. It can be a little bit strange. Next question, next slide, sorry. In the longer term, it's interesting that the bowel can in fact develop symptoms many years later, so months or years later. So sometimes you can be 3 years beyond radiation and then develop the bowel symptoms again, which can be quite frustrating. So they say it's about 1 in every 20 men that has radiotherapy to the prostate that will get some late toxicity to the bowel. Sometimes they can develop a urethral stricture, which is a narrowing of the water pipe, and then their flow would slow. We might need to deal with that as urologists. And erectile dysfunction, as with all of the treatments for prostate cancer, the nerves they're so close to the prostate, they will be in the field of radiation and will be damaged and may then not work correctly going forwards. Infertility as well. So, you know, if the chaps are still wanting more children, then we do need to consider that pre-op or pre-treatment. But it's rare, to be fair, because most men are older and have already got their families. And then longer term consequence of radiotherapy to the prostate is that can develop other cancers, so either bladder or bowel. So the rectum is obviously caught in the beam, and there's about a slightly less than 1% risk of developing a rectal carcinoma in later years. Next slide. I'll hand back to Andrew just to discuss the new thing here.
Thanks. So patients may have read about this technique called a spacer, which is a gel that's injected between the prostate and rectum. And the MRI you can see down at the bottom right shows the white, it's not white, it's a clear substance, but it appears on the scan as white, separating prostate and rectum. And the furthest right picture is before implantation, and then it's separated. The idea behind this is to reduce effect on the rectum from the radiotherapy. We normally get about a 5 to 8 millimeter separation instead of 2 millimeters. It's very straightforward to inject. It's performed at the moment just under a very brief general anaesthetic, and it goes in as a liquid and turns into a jelly which separates out prostate and rectum. There's some evidence that it reduces rectal toxicity. It's reabsorbed over about 6 months. Unfortunately, at the moment, we haven't got full NHS, we haven't got any NHS funding for this, so it has to be self-funded. But we are pursuing trying to get it funded for NHS patients at the moment. Thanks. So
radiotherapy then can be used for the T2 disease, so the organ confined, but also T3 disease, and particularly disease that's gone into the seminal vesicles, so the T3B disease, that surgery isn't really suitable for. Now, on the whole, radiotherapy is almost always given in conjunction with hormone therapy, because they did some big trials looking at the effect of this, and they found that subjecting the cancer cells to hormone therapy up front actually gave better long-term outcomes from the radiotherapy. So another name for hormone therapy is androgen deprivation therapy. Next slide, please. So when we tell chaps we're putting them on hormone therapy, they often think that we're actually going to be injecting them with hormones, but we're not. What we're doing is we are giving them a drug that actually stops them from producing their own hormone, testosterone. We know that testosterone stimulates prostate cancer cells to grow, so if we can stop the guys producing testosterone, then lowering the level causes the cancer to grow a lot more slowly. Now, 95% of the testosterone is actually produced in the testicles, and so the drug, and the other 5% is produced by the adrenal glands. So we start the patients on a 4-week course of a tablet, and the tablet blocks the receptors to testosterone. But the mainstay of treatment is the injection, and the most common ones that are currently used are Prostate and Decapeptyl. You may have heard of these. They're administered at the GP practice, often by the practice nurse, and each injection lasts either 3 months, or there are some newer ones now that last for 6 months. They're all the same as each other, they're just made by different companies. But when the first injection is given, there is actually a surge of testosterone because of the way it works before the testosterone is then switched off. And so that 4-week course of tablets is required to block the receptors whilst the surge is occurring. And by the end of the 4 weeks, the testosterone is then suppressed completely, and subsequent injections don't give any further testosterone surges. Next slide, please. Unfortunately, hormone therapy does come with a whole host of potential side effects. Because we're manipulating the hormone level, sort of mimicking really a menopausal response, so hot flushes can be quite a common side effect. Now, not every man will get the hot flushes, but those that do, they can last either 2 minutes or they can be 20 to 30 minutes. They might get just a little sweat on the forehead, or they might get a full-on body sweat where they really do soak through their shirt or their pajama top with sweat. So they can come day or night. Now, most men do tolerate the flushes and probably only get 1 or 2 a day, but there are others that don't really tolerate them. They're getting 5 or 6 a day and night, and they get quite miserable with them. They are few and far between, these chaps, but if they do, we always say to them, give us a ring and we can add in some other medications just to try and combat the flushes a little bit. And then, of course, testosterone fuels sex drive and the erection function. And so when we drop a testosterone level, we often cause erectile dysfunction. There are a few chaps that do say they can still get erections whilst on hormone therapy, but again, very few and far between. So we do have to counsel men that it's most likely that they will not get erections whilst on hormone therapy. Testosterone also gives men their sort of get up and go, and so when we lower that level right down, they do start to feel quite fatigued, especially at the start of treatment when it's a big difference. As time goes by, that fatigue can get better because they're used to the lower level of testosterone, but for some chaps it is a problem throughout. Some men put on weight, particularly around the waist, and they can get some breast swelling and tenderness, so we always warn them of that because, of course, it's a bit unusual for a chap to have breasts, and so we just let them know that obviously it could happen. Testosterone obviously makes men naturally stronger than women, and when we lower that level, they can have some issues with loss of strength and a bit of muscle mass. So the old adage, if you don't use it, you lose it, is quite true here. So we encourage them to maintain a reasonable level of exercise, use their muscles as much as they can. And for those chaps that maybe can't, so if they're sort of got mobility problems or whatever, then armchair exercises are always things that you can talk about. Having a couple of tins of baked beans in your hands and sort of arms up in the air and to the sides, and just doing bicep curls or something, just anything really to help maintain a little bit of muscle tone. Bone thinning or osteoporosis, when the testosterone level is dropped, you're at a higher risk of developing osteoporosis. So we always encourage calcium and vitamin D within the diet. And if that's not possible, then a supplement that the GP can prescribe to help with bone strength. And we always warn chaps that actually testosterone is actually what makes them hairy arms, hairy legs, hairy chest. And so a lot of that can thin out and disappear completely. So it's a change of body image, and that can be a little bit strange. So just warn them of that. The one advantage, of course, is that their beard won't grow as quickly, so they won't have to shave as often. Then obviously, when you drop a testosterone level, you can develop some problems with a bit of memory and concentration, so the menopausal effect with memory. And then it can affect the mood, so they can actually become very tearful out of the blue for no reason. So we do warn them about that. And they can get some mood swings. They can be quite grumpy at times. So again, just advise them that that is a normal kind of response to hormone therapy. And always say to them and their partners, keep an eye out for low mood. It's rare that it will cause a real sort of low anxiety, depression type scenario, but it can. So we ask them to just keep an eye out, and if they're finding that they are slipping down that way, to talk to the GP and sort of get some help there. Next slide, please. I'll hand back to Andrew for discussion of brachytherapy.
So thanks, Christine. Brachytherapy is one of the radiotherapy techniques. There are two types called low dose rate and high dose rate. Probably the commonest is low dose rate. It's not low dose, it's just the rate, it's the way that it's given. And these little tiny seeds are injected into the prostate, under a general anaesthetic using the same equipment that we use for template biopsies. The seeds stay in, it's radioactive iodine, and it gives out the radiotherapy in a very conformal, so very controlled way around the prostate gland. Not suitable for men with very large prostates, nor men who are struggling to pass urine, nor men with very fast-growing prostate cancers. It's better for low intermediate types, but is a very successful treatment, been around for many years. We do that at Poole Hospital. Normally, 2 men in an afternoon have their treatment. They're in hospital one night. Next slide, please. Side effects. They do get some of the radiotherapy effects, but perhaps a bit less than external beam. So they might go a bit more frequent to the loo. We make sure that they empty their bladder well. So retention is actually rare. They get some effect on the bowel, but less so than external beam. And out of all the treatments, it probably has the least effect on erections. But they do need to be able to have a good flow prior to treatment to have this. There is also a high dose rate where the treatment goes in, patients are asleep, and then the radioactive seeds are pushed out by pneumatic air. And so we do that as well, and that's for more advanced disease. Thanks. So afterwards, we monitor men's PSA. So unlike surgery, where their PSA will be hopefully undetectable because the prostate's gone, we see their PSA drop over about 2 years after their treatment. About a third of men may see a drop and then a rise, and this is called a PSA bounce, and is probably related to prostate cell death. But it does cause a degree of anxiety, well, quite significant anxiety in some men, so we need to strongly reassure them. But ideally, we see a PSA around 0.5 to 1 nanograms per mil at about a year to 2 years. And if it's under 0.5, recurrences are very rare. So that's the ideal. Post-surgery, we see less than 0.03, very undetectable PSA levels. Thank you. Next slide.
Right, so we'll now go on and talk about treatments for those patients who present with either advanced or metastatic prostate cancer. Next slide, please. So as we've already mentioned, if patients get metastatic disease, then it tends to move into the bones. As you can see there on the bone scan, scattered metastatic spread throughout the skeleton. So first line treatment for these men is to start hormone therapy, because hormone therapy is a whole body treatment. So it's going to treat the prostate cancer wherever it is. So it will treat the prostate and the bone disease. And what we'd like to see is that the PSA drops very quickly and then remains suppressed. Now that doesn't always happen, but on the whole it does, and we can see some quite phenomenal results. So people that have PSAs, say 300-400 to start, will drop right down into single figures hopefully, and then remain suppressed. When the PSA does start to rise again, because it will rise eventually, we can then add in a tablet that will block the action of the testosterone that's produced by the adrenal glands as well, called maximum androgen blockade, and that can sometimes bring the PSA back down for a short period of time. Next slide, please. So chemotherapy is also an option for men that have been diagnosed with metastatic disease, and the Stampede trial that took place showed that chemotherapy given at the point of diagnosis of metastatic disease did in fact improve overall survival significantly, and the drug that we use there is called docetaxel. Now, unfortunately, during COVID, obviously we were trying very hard to avoid giving chemotherapy as much as possible because of all the hospital visits that were required and the infection risks. So alternatives to the chemotherapy, there are a couple of drugs, abiraterone and enzalutamide, and we'll talk about those in a moment. But going back to chemotherapy, those chaps that are metastatic at diagnosis, they do need to have a reasonably good performance status to be able to tolerate chemotherapy. We'll go through some side effects. Next slide, please. So side effects of chemotherapy include infection. So chemotherapy will cause the white cell count to drop, and if the person then develops an infection whilst their white cell count is dropped, they can develop a neutropenic sepsis, which is quite a serious condition, and they need to be hospitalised quite quickly and sorted. Chemotherapy will cause fatigue, and they can feel very tired and weak. They might also get a bit breathless. It can cause a bit more bleeding or bruising more easily, and nausea and vomiting, loss of appetite and a sore mouth. So all of that's quite miserable. It can upset the bowel, they can lose their hair, their skin might become quite sensitive, or they might start to retain a lot of fluid. And they can get numbness or tingling in their hands and feet, and that can actually be a long-term consequence, and that never necessarily gets better. So they might have long-term numbness in hands and feet, which is really, really frustrating. They may get changes to their nails, their eyes can become quite watery, and it can affect the mood. So it's not something that you take on lightly, but it's a very good treatment, and it's very effective at treating the prostate cancer. So the oncology team will counsel the patients appropriately and give them the choice as to whether or not they want to go ahead with the chemotherapy. Next slide. So the newer hormonal therapies, I mean, they've been around a little while now. Abiraterone and enzalutamide are both used for metastatic disease. And then the new kid on the block is darolutamide, which is now a drug that can be used for patients who have been on hormone therapy. Their prostate cancer is starting to not quite be controlled on just hormone therapy, but they're still not yet metastatic. There's now a drug for that. All these treatments are actually tablet based, so we'll talk about those. Next slide, please. So abiraterone is a drug that actually just blocks one of the enzymes that is used to produce testosterone. So if you block the action of the enzyme, then the testosterone doesn't get produced. You have to take the tablets twice a day, and you also have to take a steroid alongside, and it has to be taken on an empty stomach. So there's an awful lot there, and you do have to have patients that are compliant with treatment. I won't go into all the side effects. We can look at those separately. Next slide, please. Enzalutamide simply blocks the androgen receptor, and so doesn't allow the testosterone to have its effect. So you don't need to take steroids alongside taking enzalutamide. You do have to take 4 tablets at a time though, but you can take them with or without food, so it's slightly easier from that point of view. And the next slide. And then darolutamide is the newest drug that's been released. So again, it blocks the receptors to testosterone. It was only approved by NICE back in November of last year, so it's very new. We don't have very many patients on it yet, but hopefully it will start to be used a bit more frequently. 2 tablets twice a day, and you have to swallow them whole with food. So it'll be interesting to see how that pans out going forwards. Next slide, please. So in terms of the support available to patients diagnosed with prostate cancer, clearly the clinical nurse specialist team are available for all newly diagnosed patients. We provide specialist advice, we talk them through their treatment options, and we give them lots of written information to go away with, and we signpost them to all the big charity websites as well. We coordinate their pathway, we chase them for their treatment decisions, and help them to come to a decision by giving them the information that they require. We act as patient advocate. There are some patients who just simply don't want treatment, or they want to go away and get a second opinion elsewhere, and so we are able to facilitate that for them. And if they do need to start on hormone therapy, then we will be the ones that do that. We see them in clinic, get them started, talk them through all the side effects, and then refer them on to the oncology team for further treatment. And then we run the follow-up clinics. So we do face-to-face follow-up as well as telephone follow-up. And then all patients get our telephone number for support, so they can ring at any time throughout their treatment pathway and beyond, if they've got any questions at all at any time. And then we're about to start something called remote monitoring. So next slide, please. So as I hope you've sort of realised, prostate cancer is a long-term condition, and the statistic we've got there is 78% of men survive prostate cancer for 10 or more years. So as we showed in the first slide, around 400,000 men are living with and after prostate cancer. So that's a lot of people. We clearly don't have enough clinic slots to see everybody face to face, and our telephone clinics are now full. So there's been a sort of a national drive towards remote monitoring and remote follow-up, or patient-led follow-up. So we're in the process of developing a computer system that integrates with our pathology feed, and it will pull through when the chap's had his PSA done. It will pull through the PSA level, and then the nurse specialist team will monitor remotely. So rather than having to telephone, say, 10 patients in a morning to talk through their symptoms, we'll simply have a list of, say, 40 or 50 patients who've had PSAs recently, and we'll then generate appropriate letters to them from the computer system. So we won't actually have direct contact with the patient other than through the letter. There's also a patient portal under development, so patients can then access information about prostate cancer. They'll also be able to see their own PSA via that portal, and then they'll also be able to contact the CNS team should they wish to. And if at any point the patient requires intervention, then we will just simply slot them back into a clinic to be seen. Next slide, please. So all patients that we see are given our contact leaflet. Obviously just gives all of our names and our telephone number. Next slide. The centre pages then detail all of the members of the team. So when we've seen a patient, we then highlight who their urologist is, or if they've seen one of the associate specialists, we highlight their name. And then if they're being referred on to oncology, we'll highlight the relevant oncologist that they're likely to see in clinic. Then there's a whole list of useful telephone numbers. So if they're heading off for a bone scan, we'd highlight the nuclear medicine department so they know where they're going. It talks about free prescriptions. So anybody over 60 obviously gets free prescriptions anyway, but if you're under 60 with a diagnosis of cancer, then you are also entitled to free prescriptions. So we carry the forms that are required, or the GP can fill out the form, and the patient just sends that off, and they're sent back a little plastic credit card sized card saying that they're exempt from prescription charges, which can be useful for them. And then we always signpost them to the Macmillan welfare benefits team. So if they need any support there, then they've got the telephone number and email addresses to ring. Next slide, please. And then the back page just gives information of national support services, so prostate cancer charities listed there, and then the local support services available. And when we update this, we're going to add the Wessex Cancer Matters website to that list. Next page. So we also have cancer support workers. So this is a reasonably new initiative, and there's a national drive for all patients to receive holistic needs assessments at the point of diagnosis. So wherever we can, they're done electronically via the Macmillan website, and the cancer support workers coordinate that and carry out the EHNA, and then provide care plans to those patients that require them. They also run health and wellbeing events for patients living with and beyond cancer, to obviously promote healthy living, healthy lifestyles. And then a big part of their role is to signpost patients to the other support services that are outside of the hospital. So, for instance, the Macmillan benefits advisors, any counselling services that they feel will be useful, steps to wellbeing, that kind of thing. The Wessex Cancer Trust, we're very fortunate to have them on the doorstep on Hinton Road in Bournemouth, and they offer a whole host of complementary therapies and counselling services and support for the patient and their family. They may signpost them to smoking and alcohol cessation services. Blue badge parking is really important, and of course our patients with all of their bladder and bowel issues, radar keys can be very important to those because they need to be able to get to toilets fairly quickly sometimes. Obviously, they can signpost to social services, and then there's the local patient support groups, which we'll go on and talk about. Next slide, please. So the Cancer Matters Wessex website is a relatively new initiative. It covers the whole of Dorset, Hampshire and the Isle of Wight. It's definitely worth looking at that website. There's a huge amount of information on there, and signpost patients to that website to get relevant local information. Next slide. And then the local support group. So there's a support group in Bournemouth area called Picasso, the Prostate Cancer Support Organisation. They have 3 different branches: Hampshire, Sussex and Dorset. And they are a charity that is basically run by men that have been diagnosed with prostate cancer. And they offer help, information and support to men and their families in Dorset. Next slide, please. During non-COVID times, they run regular support meetings every other month, and they do that in one of the church halls in Talbot Woods. And they often invite a speaker to talk on a topic of interest related to prostate cancer, and then they have a social sort of get together as well, and it just allows chaps to talk to each other, and the wives as well can get together. And then they run the free PSA testing events across the county as well. And to date, they've tested over 6,000 men, and some of those men have come through our clinics and then been diagnosed with prostate cancer. Next slide. Now, Alan couldn't be here today, but he did want me to just point out that they are having a bit of an issue in that they just don't have enough volunteers right now to run and manage the branch. And they are concerned that they may have to either dissolve the Dorset branch or put it into a state of dormancy. Clearly, that would be their last course of action, but they are quite desperate for volunteers because they don't have the big 3, the chair, the secretary and the treasurer. So if anybody out there does have any helpful suggestions as to how they might be able to recruit people, then he'd be very happy to hear from you. Next slide, please. And that's Alan's contact details there. So, if you do have any ideas, then please do get in contact with him. And the next slide. And then for the west of the county, there is another support group called New Man, and they cover the Weymouth, Dorchester and Bridport sort of areas and the surrounding. And I think they've got a very similar outlook to Picasso in that they just want to promote prostate cancer awareness within the community. They also provide the free PSA tests, and they provide support to any man or his family who have been diagnosed with prostate cancer. So as you can see, there's an awful lot of support out there. There's also obviously the Prostate Cancer UK charity website. They have their own clinical nurse specialists that chaps can phone and talk to and get advice from. There's the Macmillan website, and they also have support nurses available to talk through any issues. And Cancer Research UK has a huge wealth of information on all different cancers, prostate included. So lots of information out there, lots of signposting that you guys can do. And that's the end of our talk today. Thank you.